think so. Okay. All right. So we're going to.
Yeah.
Unfortunately, there doesn't look like a lot of people,
No, it's so sad, but
which is a shame. Right. I think it's probably time that we started. Unfortunately, we haven't really got a very big audience because, as you can understand, it's an orthopedic session in lots of ways. I'm Harry Frydenberg. I'm a bariatric surgeon from Australia, and with me, our moderators is Ana Casa Joana from Barcelona, a bariatric surgeon, and an orthopedic surgeon, Professor Donata Rossi. Yeah. So I don't think we'll start off today with hearing Professor Salvatore Toloni from the University of Campania at the Luigi Vanvitelli University. He's a general surgeon with bariatric experience, and he's going to discuss the new ASMBS IFSO guidelines. Professor Toloni.
Thank you very much, Chairman, for allowing me to present this systematic review, and I also want to thank Professor Angrisani for this really kind invitation. And these are my assessment, my disclosure, and this is my case mix as a general surgeon, and a special case mix for the bariatric part. I'm a previous totally a sliver, as you can see, but I also perform other malabsorption technique. In last months, we had a huge step forward because we moved with the new guidelines for indication for metabolic and bariatric surgery provided by the International Federation of Surgery of Obesity and Metabolic Disorder and American Society for Metabolic and Bariatric Surgery. And you know that there were a lot of years between the first consensus conference in 1991, so a lot of time has passed. And there are some changes, and the argument of today is the bridge to the other treatment, especially for joint arthroplasty. So the argument were about if bariatric and metabolic surgery was an optimal bridge therapy before total joint arthroplasty, total hip arthroplasty, and total knee arthroplasty, because we know that most scientific societies from orthopedic surgery usually discourage the arthroplasty in patients with a body mass index greater than 40. And so you can find the statement provided by the guidelines in which they suggest that metabolic and bariatric surgery can be effective as a bridge to arthroplasty surgery. So the task that our commission assigned me was to perform this systematic review of literature according to the PRISMA to have a strong methodological support to this new indication. And you see the exclusion criteria we used to assess the review of literature. So we excluded paper not in English, not available full text. Also, we excluded articles before year 2000, and also, as well as for all the systematic review, we excluded descriptive articles, as well as letter to the editor reviews, systematic reviews, and meta-analysis. Also, studies with follow-up less than 1 year, and those studies with short case series, so with a number of patients less than 15. The search strategy, you can see the Boolean researcher that we used, so meshing the term of joint surgery, joint arthroplasty, arthroplastic knee, and all the terms meshing with bariatric surgery and especially particular bariatric surgery intervention. And you can see our Prisma flow diagram. And the first search, we had more than 4,500 papers. We excluded duplicates, so near a little bit more than 4,000 of paper. Then we screened these 4,054 papers, and we excluded 4,011. So full text article assessed for eligibility were 43, and then we included in qualitative synthesis only 21 papers. Quantitative was not performed because the task was not to perform a meta-analysis. And regarding the grade of recommendation, on these 21 papers, we had only one randomized controlled trial. Then we had 2 studies in which was performed a propensity score matched analysis. 4 studies provided data from accreditation and quality improvement program, so large data set of patients. And then the remaining studies focused especially on safety and readmission, reintervention, or comorbidities. So you can see that only one study reached the grade of recommendation A with evidence of level 1B, and the other were all grade recommendation B and level of evidence 2B, 3B. This is the first part of the table in which you can easily see that the study design were mostly retrospective, with some studies with a larger number of patients, those coming from the large data set. And highlighted, you see the only one study from DOSI 2022, that is the only one randomized controlled trials performed on laparoscopic adjustable gastric bending. You can see I provided all the references for the 21 selected studies. So the results of the systematic review were a little bit mixed, because 4 studies reported similar outcomes for those patients who underwent first bariatric surgery and then arthroplasty, especially for total hip and total knees arthroplasty. 8 studies instead reported increased readmission rates and also perioperative complication in those who underwent first bariatric surgery. But on the other hand, we had 8 studies that instead reported diminished readmission rate and diminished perioperative complication in bariatric. And then 1 study instead reported also the diminished need to undergo total knee arthroplasty after bariatric surgery. I want to highlight only the randomized controlled trial. Even I think that there is Dr. Brown that will probably better than me highlight this study. You can see they enrolled 89 patients, then 41 were randomized to gastric bending, and instead 41 were randomized to treatment as usual. And you can see that the group of intervention was the group with the most complication-free rate, and also you can see that complication after total knee arthroplasty were lower in patients who previously underwent gastric bending. But you can see easily from the table that this result can be biased of this systematic review because we had a difficulty to establish if bariatric surgery achieved good weight loss or comorbidities remission at the time of orthopedic surgery because this paper strongly focused on the orthopedical surgery and so on the complication, but you can see we were not able to assess the body mass index at the follow-up. We were not able to assess the excess weight loss at the follow-up, as well as comorbidities resolution. So one of the bias can be a weight regain of this patient, especially for those patients coming from the large data set in which was only check out if the patient underwent or not a previous bariatric surgery. Also, was difficult to establish if those patients had, for example, micronutrients or nutrients deficiency, especially for bone metabolism, because we didn't have any data. And also, we had another bias because there is a very huge variation in the timing between bariatric surgery and subsequent joint arthroplasty. Only one retrospective study assessed by Liu if the timing was a predictive factor, and they found that if bariatric surgery is performed within 2 years before the knee arthroplasty, can effectively reduce the comorbidities after orthopedical surgery. So in conclusion, it seems that the data from this systematic review confirm the new guidelines and indication for metabolic and bariatric surgery because we have an effective on obese patient. We proposed a recommendation in which we know that bariatric and metabolic surgery is effective in achieving weight loss in patients prior to elective joint surgery and is strong and moderate, grade of evidence. Surgical weight loss is associated with reduced short-term complication after joint surgery, but long-term complications are still debated, and you see that this recommendation is a weak one, and we have a grade B and a level of evidence 2B, 3B, so we need more randomized controlled trials, especially assessing the effectiveness of prior bariatric surgery, assessing the micronutrients deficiency. And I want also to thank our group of the systematic review, and was really an honor for me working with these guys. Thank you very much for your attention.
Thank you very, very much. We've decided that what we will do is probably have a discussion at the end, unless there's anyone who wants to ask a question at the moment. No? Well, thank you very, very much. Professor Talade, thank you. Our next speaker is Professor Mario Muto, who is the Professor of Neuroradiology at the Naples University, Chief of Diagnostic and Interventional Neuroradio at the Cardorelli Hospital in Naples, has been a visiting fellow at Johns Hopkins and St. Anne Hospital in Paris, and the President of the Neuroradiology Italian Society. He's going to speak on overweight and spine function. Professor Muto.
So good afternoon to everybody. Let me thank Luigi Angrisani and the organizing committee to invite me to give this speech. What is doing in neuroradiology here in a meeting about obesity, I will try to clarify to you. The topic is overweight and spine function. The key point is there is a correlation between overweight and spine pain and degeneration of the spine, or it's only a fake? Is it true or it's fake? I think this is one of the questions that I often receive by patients. I'm mostly interventional neuroradiology, doing a lot of spine percutaneous treatment, and very often I'm dealing with this type of patient, and I try to explain them with that the loss of the weight is mandatory if they want to improve the situation. So the key point is always to understand why do I have pain, and the point is that the source of spine pain can be multifactorial, and we can distinguish between two different types of syndrome, that is somatic autonomic, and of course, as a vertebrogenic pain, that is the most common situation, we can distinguish between nociceptive and neuropathic, and by breakthrough, that is oncology patient. When we are dealing and evaluating our patient, we should always, first of all, to understand clinically the source of the pain. And to do this, of course, we have also the help of diagnostic imaging, and we must offer to our patient a complete therapeutic program that is not only percutaneous, but very often physical therapy. And I will explain why is a so important physical treatment. But we should go back. We should go back to what is the biomechanic of the spine, because biomechanic and the stand-up position is absolutely a miracle. And that involves multiple situations like skeletal adaptation, muscular adaptation. There is a multiple sensory involvement. There is a central control of coordination, anticipation of the movement, and adaptation of the motor answer. And all these together, working together as one goal, only one goal, that is to save energy. Now, one of the concepts that is very important at the level of spine is the stability. Stability is related to the spine, to something that gives the capacity to the vertebra to remain cohesive in all the body physiological movement. And the stability factors include the physiological curvature, the structure and architecture of the vertebra, the intervertebral joint, the ligaments, and the muscles. We all know that we change the position when we are a baby up when we stand up. So we move from one only curve, that is the kyphosis, to 3-4 curves when you stand up. And the reason is very simple, because the curvature increases the resistance over 17 times comparing with the straight spine. So the curvature is very important for the load of the spine. And also the architecture of the vertebra is very important, because there is a tridimensional beehive structure, very similar to airplane wings, giving the best resistance weight ratio. And you know that moving from cervical to thoracic and lumbar spine, the dimension of each vertebra is going to increase because there is more load. And so, of course, this is the answer to the increase of the weight of our body. We have also 3 different systems, one vertical, one horizontal, and 2 curvilinear structure that also increase the resistance of the vertebral body. And what is also very important is, of course, the disc. The discosomatic unit, you know that there is no cortex in the superior and inferior end plate, and the disc does not receive anymore the arterial supply from the age of 16, 17 years old of everyone. And so that's the reason why there is a physiological degeneration of the disc. And this is the only way that can feed the disc is with the colloidal osmotic pressure. But this is not sufficient to give, to repair the disc after shock term. But what is also very important is to remind that in case of experimental study done on the disc, and in case of axial load, it's not going to rupture the disc, but it's going to rupture the end plate. And this happens very often with the biphasic reaction. The apophyseal joints are also very important because they regulate the direction and the largeness of the movement, and they participating, of course, also to the axial load of the patient, of our body. And we have the 3 columns theory, that in which there is a very symmetric distribution of this load, that from atalo-occipital joint is moving to C2 to L5 in 3 columns, and at the sacrum is going back again with the 2 forces. What is very important is also that the load to our vertebral body can be distinguished in anterior and posterior. And when you are getting older, unfortunately, the weight, even in erect position, is going to move from the anterior axial load more to the posterior element. And this is something that, of course, can be even worse in patient overweight. So if we look to this patient, of course, we are going to see that in patient in erect position, there is maximum load in the anterior column, while in flexion, we are going to have more load on the facet joint. What is very important is also the symmetry of the facet, because the asymmetry of the facet predisposed to rotatory instability. That is also something that is very important for the spine pain. So when we look to our image, it's very important to look to this type of orientation of the facet joint, because otherwise you can have a rotatory instability, or you can have so-called degenerative spondylolisthesis. And look always to the angle that we can have, because if you have a sagittal orientation of the facet, this is something that can absolutely increase the risk of spondylolisthesis. We know also that we can have sometimes retrolisthesis. This is happen when there is a disc degeneration that is prevalent on facet joint degeneration, causing a spinal foraminal canal stenosis. The ligaments are also very important, and very often we have a very important factor that is so-called the instant axis of rotation. It's the point, the fulcrum about which the vertebra rotates in all the movement. This is something that is also very important to remind. The ligaments, they do not reduce significantly the largeness of the spinal canal during the extension, but they have an action on elastic recall after flexion. So how can we study this instability? We can study with dynamic MR. So we can have, in a supine position, we can perform our acquisition. And we can also maybe have a look to this type of facet widening that you see very bright signal at the level of the facet. And when you do the same acquisition in upright position, the same patient, you can see there is a mild spondylolisthesis. But this is very painful for the patient. But this is the key point. Muscles. The muscles are absolutely active stabilizers. The anterior are flexors and the posterior are extensors. And those are structures that are very important to stabilize all the vertebra. And there is this type of spine balance theory in which, of course, the posterior muscles operate with a powerful lever upon the posterior arcs, and that tends to open the discovertebral space, and this tries to reduce the discal pressure. So what happens if you have a normal patient? You have a normal patient, you are going extensor, you have flexors anteriorly, and of course you have also the action of the viscera, the abdominal viscera. What is going to happen? When you are in contraction, there is increased pressure, and the muscles must be able to support the weight of the body. But what happened, this is what happened in a normal weight situation, in which there is a very good balance between the anterior force that is balanced by the muscles and the posterior force balanced by the vertebra. What happens if you are overweight? It's completely abnormal, because there is a reduction of the action anteriorly, while there is an increased action on the posterior element. Of course, very important are also rotation and rotational movement, and the consequence of this degeneration of the spine is the stability, that is so-called the loss of the ability of the spine under physiological law to maintain relationship between vertebra. And it's not a so-called not called all or nothing phenomenon. It's something that slowly is going to happen. But there is a last point that is very important for spine stability, that is some extra spinal factors, that is the pelvic factors that are very often are absolutely independent and congenital. So we know that the curve are not the same in all the patients. And when we moved up from 4 legs to 2 legs, there was a change in morphology, morphometry. of the pelvis. And what happened is that what is really important is also the angle of pelvic incidence that is going to influence also the spine degeneration. It is reflects the sagittal morphology of the pelvis. This is our pelvis usually, and we can, how can we calculate this angle of sagittal incidence? We should identify the sacrum, the femoral head, and of course center the femoral head, center the superior border of S1, straight a line, and you will see that this line is going to change position in relation to the congenital situation of the sacrum and the pelvis. Of course, this line reflects the dimension of the pelvis, and there is something that we cannot change. However, this is going to influence a lot also the spine, especially the lumbar spine. And if you take a line between the perpendicular of S and the S1 level with the angle of the center of the femoral head, you have this angle that is the angle of pelvic incident that really influence a lot also the degeneration of the spine. So this is something that is characteristic of each individual man or woman, and characterize the morphology and width of the pelvis, and of course influence also the equilibrium of the spine. So the conclusion are that if those are stability factors, of course this can be pain generator, and this is one of the reasons why overweight has more pain, but overweight influence absolutely the load at the lumbar spine, cause shift of the load from the anterior column to the posterior elements, especially if not compensated by muscle action, with acceleration of the degenerative spine process of the discosomatic unit at the level of the apophyseal joint. So diet and physical activity are mandatory to prevent further spine degeneration. And let me show you this beautiful picture of the last championship we won in Naples recently. Thank you very much for your attention.
Professor Muto, thank you very much for that erudite description and information, because I'm sure us as bariatric surgeons are unaware of all the physical factors that you've shown that are involved in the spinal movement. We'll leave again questions till the end. Our next speaker is Professor Rafael Russo, who is a professor of orthopedics at the Malise University Medical School, chief of orthopedics at the Pinte Grande Hospital, expertise in shoulder and elbow surgery, and a pioneer of the open arthroscopic shoulder surgery, the Randelli operation. Again, he's past president of the society, and he's going to talk on the shoulder arthroplasty in people with obesity, timing in the candidate to obesity surgery.
Thank you very much. Good afternoon, everybody. Mr. President, dear colleagues, my presentation will be about the shoulder arthroplasty in people with obesity, with particular timing in the candidate to obesity surgery. Hemiarthroplasty, anatomic total shoulder arthroplasty, and the reverse total shoulder arthroplasty are the most common devices used treating degenerative shoulder disease. In particular, the shoulder joint pathology are concentrating concentric osteoarthritis, osteoarthritis with rotator cuff tear arthropathy, proximal humerus fracture, and the revision of failed arthroplasty. The rates of obesity have continued to climb and impact healthcare in multiple capacity all around the world. Its influence on outcomes and complication rate within the arthroplasty populations has been of great interest for the orthopedic community. But
if extensive literature has been published on the skills, risks, and benefit of bariatric surgery prior to and following lower extremity arthroplasty, less similar investigation have been performed on the impact of bariatric surgery prior or after to total shoulder arthroplasty, and particularly on his precise timing. In other words, the literature about this topic is very poor. The aims of this presentation are to summarize the effects of obesity on the shoulder joint, to precise the types of complications and outcomes of shoulder prosthesis in obesity population, and to report our personal experience treating obese population with prosthesis, and make a focus on the most correct timing of bariatric surgery in obese patients affected by shoulder pathology and needed of joint arthroplasty. In other words, this presentation is a mix of a narrative review on the shoulder prosthesis obesity and the expression of our personal experience, because from the April 2018 to April 2022, we treated 414 shoulder prosthesis, and with a follow-up of 303 patients. In total, we treated 72 obese patients. Just a few words about the obesity background. We know that body mass index is important and is a common method to measure obesity levels. A BMI greater than 30 signifies class 1 obesity, while BMI of 14 or greater implies morbid obesity. A BMI equal or superior to 40 or BMI equal or superior to 35 with comorbidity are a threshold for surgery that universally is applied. What effect of obesity in glenohumeral joint? Patients with higher BMI are at increased odds developing glenohumeral osteoarthritis. All BMI cohorts of greater than 30 demonstrated significant greater odds of having shoulder osteoarthritis than BMI from 90 to 24 cohorts. There are also increased odds of undergoing arthroplasty in the higher BMI cohorts that is disproportionate to increase in osteoarthritis rate in these cohorts. Which effects of obesity on the shoulder pain? The shoulder is a very particular joint in the obese patients because there is a significant association demonstrated between total body fat mass and the widespread pain. Pain-relieving treatments are less effective in obese patients, even though they report higher pain intensities than patients of healthy weight. This is likely multifactorial as chemical mediators due to the fat accumulation and also psychiatric diagnosis that can impact on health condition. What about the obesity and the brain condition? Anxiety occurs more frequently in obese individuals. That is most important in the shoulder implant. Insulin resistance is greater in obese individuals, while anxiety compounds this to further increase insulin resistance. Therefore, acknowledgement of comorbidity conditions and how they influence one another is a valuable insight to the complex medical condition of obesity, which orthopedic surgeons commonly have to consider in their patient population. Some question about the obesity and the influence of the obesity on the diagnosis and planning for surgery. We know that CT scan images, MRI, can affect by many artifacts. And this problem needed a solution to solve that. And it's important to have an advanced imaging with the TC scan technique by enhancing understanding of joint geometry. The obesity can influence also the surgical approach. Of course, the surgical exposure, the position of the glenoid can be a challenge with a great soft tissue envelope due to its depth position. Positioning the arm in adequate adduction when the surgeon implants the prosthesis can have the difficulties due to the size of the arm and the torso. Which solution for that? We need the artificial intelligence and patient-specific instrument, as in this case of obese patients with secondary osteoarthritis with an important dislocation of the head posteriorly, and this is the plan using artificial intelligence for implanting a correct metal back, correcting the retroversion and the bone loss of the glenoid. In this slide, you can see the PSI that we used in case of obese patients to perform a correct implant of the pin of the metal back, and at the end you can see the picture of X-rays of this patient. The literature about the complications and readmission in postoperatively patients operated with anatomic or reverse total shoulder arthroplasty is about 7.5%. The most common perioperative complications are medial complication, around 13.5%, shoulder dislocations, glenoid positioning, humeral fracture, venous thromboembolism, but also infections, about 15%. There are also early complications, as early wear or aseptic loosening that are most common concern about complication in these patients. There is a possibility that weight of the arm following surgery may incite a distraction force causing shoulder dislocation. Furthermore, many larger patients rely on their arms in assisting mobility, thus risk for injury due to the instability or early use of the extremity. About the late complication, we can read in the literature the percentage of around 8.7% as acromial fracture, glenoid loosening, humerus fracture, and also infection. Which is the evidence of the risk of complication implanting the shoulder prosthesis? The literature about is very poor, but in some studies we can conclude that the obesity, when other major comorbidity are controlled for, was not associated with increased risk of short and long-term surgical complications. In this slide, we can see our experience testing patients at follow-up from 1 to 4 years, and our conclusion are that there are no significant differences in complications between non-obese or obese patients. What about the timing of bariatric surgery? We make it prior or after total shoulder arthroplasty. The literature on this question is confusing and controversial. We can see here the last study of Professor Sanchez Sotelo and Sperling from Mayo Clinic that conclude that primary shoulder arthroplasty in patients with prior bariatric surgery demonstrated an elevated complication profile when compared to matched cohorts of patients with no history of bariatric surgery and either low or high BMI. These risks were more pronounced when shoulder arthroplasty was performed within 2 years of bariatric surgery. In opposite, this is another study. Its conclusion is that bariatric surgery following total shoulder arthroplasty is associated with increased rates of mechanical complications, including instability and loosening, compared with the bariatric surgery prior to total shoulder arthroplasty. These findings suggest that it may be prudent to consider performing bariatric surgery prior to total shoulder arthroplasty in morbidly obese patients, rather than waiting until after total shoulder arthroplasty is performed. In conclusion, while obesity has been identified as possible risk factor for increased mechanical complication following total shoulder arthroplasty, there is a lack of literature evaluating the effect of bariatric surgery either pre- or post-operatively on real incidence of complications. Bariatric surgery after total shoulder arthroplasty is associated with a higher rate of mechanical complications. Furthermore, this association of mechanical complication was not noted in patients who underwent bariatric surgery prior total shoulder arthroplasty. Thank you for your attention.
Professor, thank you very much for, once again, a very erudite summary of the area in the shoulder surgery. We'll get to, as I mentioned, to questions at a later time. Our next speaker, Professor Donato Rossa, who is here next to me, has nominated his fellow, Giovanni Ballato, who's at the University of Napoli Federico II. And he's going to talk about the knee arthroplasty before and or after bariatric surgery.
Good afternoon. Thank you very much, Chairman, for the presentation. I want to thank also Professor Angrisani for considering also carpenters in this fantastic congress. And we have to discuss the relationship between obesity and musculoskeletal joint disease.
Perhaps a little bit closer to the microphone.
Yeah. Okay. So when I was preparing this presentation, I wondered why are we talking about obesity. So I tried to figure out the main reason, and I found these three main hot topics. The first is the number of obese patients. The second is the relationship between obesity and joint disease. And the third, you have already heard about this, that obesity is correlated with post-operative complication. The number. As you all know, the number is increasing in the Western world. It is estimated that more than 39% of the population is obese. And obesity is also considered the second cause of death in the United States of America. So it's a very huge problem. We have to deal with it. And this number will increase in the next future. So there's a paper from New England Journal of Medicine. So the prevalence of overall obesity and severity obesity will increase in 2030. And this obesity involve particularly women, Black, non-Hispanic adults, and low-income adults. If we move to our latitude, so in the European countries, we found that are the winners in terms of prevalence of the obesity. We have at first place Ireland, followed by Greece and Scotland. And fortunately, Italy had the lowest projected prevalence for the obesity. But anyway, the costs are very high, also for the Italian healthcare system. In fact, it is estimated that the economic burden, so the total burden of obesity in Italy is over 13 billion of years, considering either direct that indirect costs. The second point is the relationship between obesity and musculoskeletal diseases requiring total joint arthroplasty. It is well known there is a correlation between these two diseases. So the obesity also is a factor for a progression of severity of osteoarthritis. and also the number of total knee arthroplasty will increase in the future, starting from 2011, in which from 2011 to 2013 we have a decrease of people with a normal weight, and in 2023, so now, the 66% of our patients are obese or morbidly obese, and this number will increase in the future. The third point is obese patient, the obesity as a risk factors. Which kind of complication increase in obese patient? All the complication, general, so specific or non-general complication. Specific complication I will list in this slide. We talk about wound essence, infection, anemia, as in this picture. In fact, BMI, increasing BMI is associated with the increased risk of wound infection per unit of BMI over 35. But not only biological complication increase in the obese patient, but also mechanical, as Professor Russo said before. So BMI over 35 is associated with a high rate of implant revision for accepting loosening. For these reasons, the American Association of Hip and Knee Surgeons established that total joint arthroplasty should be avoided in morbidly obese patients with BMI more than 40, because the complication profile may outweigh the functional benefit of the total joint replacement. In fact, when one of these complications, and in particular infection, occurs in this patient, is a very dramatic scenario. So in fact, for example, infection, the outcome are worse, because if you look at the rate of the reinfection in this patient treated with two-stage that we use in patients with PJI is about 22%. So 22% of patients treated for infection experience a recurrence of the same infection. But we have also a high rate of other complications. So what can we do for this patient? We can optimize patient, so mitigate the preoperative risk, and also manage in proper way the surgery. It is a very important topic for our school, because 15 years ago, Professor Rosa published the Italian guideline on the obesity, and now we are still discussing about this. Optimization of the patient. This is another lesson we have learned by general surgeon, because we share the fast-track protocol. This is now a standard of care for all our patients. And one important pillar of this fast-track protocol is the optimization of the patient. So we have to study all the risk factors and try to modify them. So of course we can modify also only the modifiable risk factor, and this is the 12 most important. And if you see at this slide, we have diabetes, obesity, malnutrition, that in most of the cases are correlated to each other. So we have to focus our attention on this. But with diabetes, we know exactly the goal we have to achieve. So we have to maintain glucose less than 200, hemoglobin, glycated hemoglobin less than 8, and fructosamine level less than 292. Also, malnutrition should be corrected. In fact, malnutrition is correlated with wound problems and hematoma formation, and of course infection. And we, in this case, we have these markers. We have to pay attention on this and correct them with, of course, supplement, protein supplement, iron, or vitamins in general. But for the obesity alone, we have only BMI. And the question is BMI actually the right thing to use to characterize obesity? This is the first paper by Javad Parvizi that tried to find a BMI cutoff to predict the failure. But he don't reach this goal. So BMI is not the only parameter we have to analyze. Because not all patients are created equal, so we have to focus on fat distribution, or more specific for knee joint, we can consider the fat thickness around the knee joint. This is two papers of the same author, so it's biased, about the bioelectrical impedance to study the fat distribution, and is a predictor more accurate than BMI to predict, of course, failure. And these two other parameters, we have the prepatellar thickness and the pretubercular thickness by a simple X-ray, so more than prepatellar thickness more than 15 millimeters and pretubercular more than 25 millimeters increase the risk of early reoperation in total joint, total knee replacement. This is confirmed by another study in which the author considered also the fat, the thickness on the medial side and on anterior side. But another important concept we have to keep in mind is that weight loss is unrealistic for most of the patients. So only 70% of morbidly obese patients attain a BMI under 40 with a lifestyle changes. So bariatric surgery can be a factor, an element to prevent complication prior total joint replacement. I studied only orthopedic literature on this, so we have 2 case series, 1 registry-based study, and 3 meta-analysis. With confusing results. So in the first study, of course, patients in bariatric group have a higher risk of reoperation than patients with a high BMI or low BMI group. The same results, the risk for infection was higher in bariatric surgery group before, of course, total knee arthroplasty. If you look at the meta-analysis, this included only 5 studies. We have no statistical difference in outcome between bariatric group and non-bariatric group, so it is not something that can reduce the complication. Go on, patient who underwent total knee arthroplasty after bariatric surgery had lower short-term medical complication, so it's positive, but no statistical difference at long-term complication. Another study, no difference in terms of stiffness, revision, or infection short-term, no difference, or for some complication is a higher risk. So this is a sort of conclusion. Patients having bariatric surgery prior to their total knee arthroplasty have similar 1-year outcome regarding pain, joint function, and satisfaction. This is the main reason for this, why bariatric surgery can reduce or increase the risk. This is correlated to medical or psychiatric comorbidities, the rapid weight loss before surgery, age, and wound healing correlated problems correlated to malnutrition. But some patients should not be operated. BMI over 40 with other comorbidities, when we cannot reach an optimization before the surgery with patients with open wounds, venous problems, and when they don't try to lose weight. The second point, and this is the last point, is more technical for orthopedic surgeon, so is manage the surgery. Of course, patients have some issues, okay? We have difficulty to identify anatomy in some cases, so this is correlated with a higher risk of bleeding intraoperatively and postoperatively, and this is correlated also to mechanical failure. we have to prepare the hardware, the environment. So we need a special bed, special tourniquet, dedicated instrument, and an increased number of assistants. But also we can come back to a concept I have already said before. The obesity is different from male and female, for example. So if we operate a male with this kind of fat distribution, has a problem, but different when a female with obesity, subequatorial involving leg, we have to perform this angle. So we have to calculate this angle. It's a thigh-calf angle, because if it is less than 100, we can damage the medial collateral ligament to expose the joint. So we need a constrained prosthesis in operative room. Okay. In other cases, we can use each prosthesis are present on the market. But always use cement to reduce the aseptic loosening, and also a thicker polyethylene to reduce the wear at short term and long term. Another point is the management of the wound. The wound is very important for us, because if the wound has problems, we have a big problem, in particular in this patient. So it is our algorithm on this, and for obese patients we use an incision negative pressure therapy that promote wound healing, avoid wound drainage, avoid blistering, and prevent superficial wound infection. Another chance we have is to extended antibiotic prophylaxis only for high-risk patients to reduce the most dramatic complication, that is the infection. So in conclusion, obesity, in particular morbidly obese, are a risk factor for all the complications, mechanical and biological complications. Obesity is not an isolated disease, is correlated with other comorbidities. Consider all you know, and in particular an evidence-based approach to optimize patient. BMI is not the only parameter you need to correct it, to optimize the patient. Bariatric surgery, until now, appears to lead to a potential risk and complication. Thank you for your attention.
Thank you, Professor Bellato. Again, one of very interesting insight into the field in relation to obesity and orthopedics in that regard. Our next speaker, who I know very well because she's a colleague from Melbourne, Australia, Professor Wendy Brown, is very well known as a very leading bariatric surgery, and she's the chief of surgery at one of our major hospitals. She's also very involved in registries, and she's an expert involved in the forming of the local bariatric registry in Australia, but also the IFSO bariatric registry, which we've all recently got new copies. So without any further, I'm going to ask Wendy to talk on, does preoperative bariatric surgery reduce the need for total knee replacement operations?
Thank you very much. Thanks, Harry, and thank you very much for coming along to this session. It's certainly been very interesting for a non-orthopedic surgeon. These are our disclosures. So I'm going to present to you basically the work we did in our randomised controlled trial, which was done in conjunction with St Vincent's Hospital in Melbourne, led by Peter Chung and Michelle Dowsey. The reason we did this trial is that osteoarthritis of the hip or knee is one of the most common diseases in the world, and at least 50% of people will go on to have a total knee arthroplasty at some stage during their lifetime. We know that obesity contributes to the genesis of osteoarthritis, it drives the symptoms, and it's overrepresented in people presenting for total knee replacement. As we saw in the last talk, it can lead to some challenges, and it's estimated that people who with obesity who undergo a knee replacement are more likely to have a poorer outcome. And the group at St Vincent's demonstrated previously from their large database that the risk of post-operative infection was around 12 times higher. There's also an increase in in-hospital mortality and morbidity and a reduction in quality of life. And the joint itself probably doesn't function as well as it should, as we heard just previously. So there have been a number of case series looking at the impact of weight loss on total knee replacement outcomes. Calorie-reduced diets prior to arthroplasty can improve outcomes, but these are only case series, and not every series, as has been already mentioned, did demonstrate any benefit. And most of the case series tended to include people that also have overweight as well as obesity, muddying the waters somewhat. And there was only very short-term follow-up in most of these series. And there was absolutely no higher level evidence supporting weight loss prior to arthroplasty for people with higher grades of obesity and advanced OA. So we hypothesised that the clinical, functional and quality of life outcomes for people with obesity, meaning a BMI of greater than 35 undergoing a total knee arthroplasty, would be improved if this was preceded by a bariatric procedure. We aim to determine whether or not the incidence of post-operative complications and patient-reported pain and function could be improved for patients with obesity and end-stage OA if the knee replacement was preceded by significant weight loss. This was the design was a parallel group assessor blinded randomised controlled trial, and we planned to have a minimum of 12 months follow-up following the total knee replacement. We recruited patients through a public hospital in Melbourne, St Vincent's Hospital, which does a lot of statewide referrals in our state for people with very advanced grade 4 OA of the knee. We had 82 patients who were waiting for a total knee replacement who were invited to participate, and half of the group were subjected to a laparoscopic adjustable gand prior to their TKA. The joint replacement was to be triggered at either 12 months or once the patient had achieved 20% total body weight loss. The main outcome was a composite outcome that was based around the complications of arthroplasty, and that included death, peri or post-operative complications resulting in a discharge delay, an unplanned procedure, or readmission at study close. And we had secondary outcomes of hospital bed day utilisation, anthropometric measures, and patient-reported outcomes. The trial took a long time because things, as I'm going to show you, didn't quite go to plan. Because when we recruited, the orthopaedic surgeon said, you need to understand these are patients who cannot avoid a knee replacement. And the bariatric surgeons were saying, but if they lose weight, they may not need their knee replacement. But we were convinced by the orthopaedic surgeons that all of these patients would need the degree of arthritis in their knee was so bad that there's no way they'd avoid an arthroplasty. So therefore we powered everything around post-operative complications. But what actually happened was in the group that underwent LAGB, you'll see that 12 out of the 41, so around a quarter or a third, actually declined TKA. So they did not go on to have joint replacement surgery during the trial. So that complicated things a bit. These are just our inclusion criteria. You'll see that the demographics at baseline are well matched, although the WOMAC score was a little bit lower, a little bit higher in the treatment as usual group and a little bit lower in the gastric band or bariatric surgery group. So if we walk through what happened, the patients had their consent, and then 41 in the treatment as usual group went on to have their knee replacement surgery at a mean of 118 days after being recruited, and their primary outcome was measured, being this composite score, 27 months afterwards. And of those, there was a number of complications. But in the LAGB group, as I mentioned, there was 41 patients that went to 39 patients when they were randomised to an LAGB who decided they didn't actually want to go ahead. That was probably matched by the 2 that were not fit for surgery in the treatment as usual group. But then we had the problem that 10 people of those 29 no longer wanted to go on and have their arthroplasty surgery. So the day that they had their knee replacement was really day 0. And so what we had to do was work out how many days it had taken from the treatment as usual group to get to day 0, and then we had to match that on the group that, on the bariatric surgery side, so that we could say that they were all given 12 months from the day of surgery and had not experienced the primary endpoint. It became very, very complicated and well beyond a simple bariatric surgeon's ability to understand, because I have to say Peter Chung and I were like, well, why don't we just report this? But the epidemiologists made us do it this way. So it really made the trial a lot longer. In that period of the LAGB group, 2 bands were removed for infective complications and 1 port was revised. And all of those went on to have knee replacement surgery, and 2 had the primary outcome. So under intention to treat, they are actually included in our groups. Sorry, I flicked through that a bit quickly. So you'll see that there was a major difference in the survival from complications. So the people who did not get complications, for the people who had an LAGB prior to having knee replacement surgery had fewer complications. Fewer of them reached that final endpoint than the group that went straight to surgery. Of our secondary outcomes, we didn't really see any difference in the length of stay. We didn't see any difference in the rehabilitation, but we did see a difference in weight change with the group that had had bariatric surgery, on average having lost 16.5 kilograms over the period of the trial. So this trial became a bit complicated, but I guess the take-home messages were that people who lost weight with the assistance of a bariatric procedure, around a third of them did not actually go on to have their knee replacement surgery during the period of the trial. It's very likely that they will still need a knee replacement at some point, but that got pushed out, and when they did undergo a procedure, they were less likely to have a complication. This study is limited by the fact that we limited them to the age under 65 years of age, because in Victorian public hospitals we cannot offer bariatric surgery to people over the age of 65, and many needing arthroplasty fall into an older age group, so that's one of the major limitations. The intervention was the gastric band, and that's because we started this trial in 2012 and it was a preferred procedure at that time, and we know it's now not commonly performed. But when you think that they achieved 16.5 kilogram weight loss, that's very similar to what they could potentially have achieved with a GLP-1 agonist or some of the other newer medications. Therefore, it might make these findings more applicable to the real-world setting where most people are not going to be able to access bariatric surgery. And it's also possible that we'd get even better results with the diversionary or resectional procedures, although there is always the risk that if they lose more weight, that they lose muscle mass, and it might actually be a negative effect, and so that really does need to be studied. And as mentioned, there was a longer than anticipated length of trial due to this unexpected finding that 30% of our patients who underwent an LAGB did not ultimately require a total knee arthroplasty during the period of the trial. So this has changed our practice. This is a busy slide, but this shows that at our practice, at our hospital, patients, before they get to see the orthopaedic surgeons, go and see a physio-led clinic where they're given exercises and they're really tried to precondition them. We're now getting them to see not only a pain specialist, but they're offered weight management at that, if they're in the obese category, at that pre-hospital clinic. And they're only referred through to the orthopaedic surgeons once we're sure everything is optimised. So, in conclusion, weight loss following bariatric surgery reduced the risk in our trial of complications following a total knee replacement in people who are under 65 years of age with advanced OA and a BMI of greater than 35. But 30% of those who underwent an LAGB as a prelude to arthroplasty did not require a TKA during the period of our trial. And as mentioned, I think that means there's opportunities potentially for better outcomes with newer procedures, but not necessarily so. It could also be a negative, and it's possible that medications may be a good alternative to surgery in this setting. So I think it's appropriate that the IFSO and the ASMBS have been rethinking indications for bariatric surgery, and I was really pleased to see that arthroplasty was actually considered in this document. And I think our trial, I know it's a small trial, it's got its flaws and it's got its limitations, but it does send through a strong signal that weight management should be a very important part of anyone who has obesity, who is with advanced arthritis, who is considering arthroplasty surgery. And these are just some of these medications that I mentioned. that are going to give us very similar results to our bariatric surgery. And just a little plug again for our conference in Melbourne next year. That's my hometown. We'd love to welcome you there. It's a great place to visit. And we'd very much enjoy welcoming you down under. I like to show off my hometown. This is the view from my apartment in the morning when I get up and go to work. It's a really beautiful city, and we have a lovely river that runs through it. It's very safe. We have wonderful cafes. We have a very vibrant laneway culture, very much driven by our Italian population and Greek population. So I think you'll feel very at home if you come and visit us down under. So thank you all very much for your attention, and again, thank you for this invitation.
Wendy, thank you very much. Now can I ask all the speakers to come to the front? We're going to turn the chairs around, and we'll have you sitting facing the audience, and we'll have question times. Anna Casioana will lead the questioning at this stage.
First of all, thank you very much, because I think all the bariatric surgeons that are here today will learn a lot of things about the lessons that you explain us about the orthopedics, all about the anatomy, and about all that you explained. So it was a pleasure. And of course, it's always a pleasure to listen to Professor Brown with all this study, that she is always so meticulous with all the team, with studying all the points of this study. So the first question probably is yeah. So the first question is about what do you think in the orthopedic outpatient clinic when you receive a patient with a high BMI and you have that this patient has indication for an orthopedic replacement? How do you explain that before this that the best option could be first bariatric surgery and then the orthopedic? Because I think that when this type of patients arrive to my outpatient clinic, they don't know exactly what is bariatric surgery. Most of them are older. They don't understand why they need to modify the alimentary habits and everything. So how do you explain to these patients?
Can I start? Okay. It's a very important topic, because some patients are not in a program, so they don't know how to lose weight. So we try to explain the complication of a total joint replacement in general, so the systemic and local complication can in most of the cases are very dramatic. So we try to not scare patient, but try to convince to modify lifestyle in general. I don't know your experience.
Our idea is the same. It's difficult to explain for these patients the importance to lose weight, but sometimes the patients see that the pain is so much high, and the decision goes to the surgery. Mm-hmm. And in my experience, I treated patients overweight without problem for shoulder surgery, for shoulder implant. Of course, we noticed some difficulties as a general aspect during the operation. It's true that the implant of especially a reverse prosthesis is very difficult, because the glenoid is very deeper, and sometimes it's important to have a PSI to implant this prosthesis. And of course, it's important to explain all problems intrinsic and extrinsic to the procedure. I think that we don't constrain the patients to change completely the idea. for the problem of shoulder surgery. I think that is different the problem for knee surgery, for knee prosthesis.
There is other question? May I have a question for all speakers? What do you think about, because for me, at the end of this discussion, I don't understand well if all of you, the speakers are think about if it's always want to perform the bariatric surgery before, and how many times after the bariatric surgery to perform total knee or total shoulder or total hip arthroplasty, because I read the literature is very, is not univoc. So also the Tolone show some numbers, but it concluded it's better to perform before. The result is better, but the other say not the same thing. So for me, I just a little confused. I'd like to, after this discussion, is better for the people and for the guidelines to understand better I think the best things of our discussion. What do you think about?
Thank you very much, Professor. Well, you correctly highlighted what is the actual problem. When Balato, Russo Muto showed their slides, I had nightmares because of the 4,000 paper I reviewed for doing the systematic review. And the lot of them, most near 4,000, were only about the influence of obesity on the arthroplasty, as they showed. And we have some sort of paradox, of the obesity paradox. Obesity can increase complication and problematic for the arthroplasty. So it can be intuitive to say, okay, having a weight loss effective achieved by bariatric surgery should decrease this rate of complication. But on the other hand, on the few data we have about literature, we have very contrasting data, because we have some papers dealing with weight loss and they are doing well, as the optimal paper Professor Brown presented, that is the only one randomized controlled trial. And I must rely on a level 1 evidence, that is this paper. But on the other hand, we have a lot of biases, so we need a better trial as the one Professor Brown performed. Then we have to understand what kind of bariatric surgery we need to perform. So starting with this experience with the bending, we should say, okay, we need a weight loss with the restrictive procedures in order to avoid micronutrients malnutrition, in order to avoid problems on bone metabolism. Probably yes, but I don't have data to answer to this. So probably we should design trial also according to the different type of bariatric surgery. Or why not using drugs as liraglutide that they are doing really well. So I think that in the future we need a lot of research, and with well-designed trial as the one of Professor Brown.
Yeah, I agree. I think exactly with what you say. I think there's definitely room for more trials. I know that there are some trials going on at the moment looking at medications, but some of the medications that will come to market by the end of the year will deliver similar weight loss to sleeve gastrectomy. And I think they're going to be a different set of medications again, because there is this fine balance between losing adipose tissue and taking stress off the replaced joint, but not harming the bone and not losing muscle mass. And so in some ways that's why we chose the band. The sleeve was around, and obviously Roux bypass, but Professor Chung was more keen on the band because he felt like it was a more gradual weight loss and we had evidence to show that it preserved muscle mass and bone mass at 12 months. And also I think because you guys deal in joints all the time, he's like, what's the problem of putting a prosthesis in? So that was the reason that we went that way. But I think there's plenty of room for more trials.
Who would else like to speak on this? No?
I am a spine mini-invasive therapist, and I can tell you that my surgeon in the hospital does not absolutely like to operate obese patient. Or every time that there is a porotic fracture or there is a herniated disc in obese patient, he asks me always to try before with minimal invasive treatment and after as a last chance to operate. They know the rate of failure in those patients is much higher. And for this reason, there are no doubts that we know if this can be avoided, open surgery is much better for them, without any doubts, even without a trial.
Okay. From the audience, there was a question.
Sorry, my name is Jim Byrne. I'm a surgeon from the UK. Thank you very much for putting this afternoon's talk. It's a shame, really, there aren't more people here, but I thought it was very powerful. I came here full of hope, really, that I was going to be presented with evidence, because it makes a lot of sense that if you lose weight, you modify the inflammatory milieu and you help with symptoms, you deal with some of the mechanical problems related to excess weight that exacerbate musculoskeletal pain, presumably. And it is a huge disappointment with the evidence really does not seem to support in a high quality manner, other than Professor Brown's study, weight loss surgery as an upfront intervention, accepting the guidance is what it is. And I wonder really if the panel have a view as to what the problem is. I mean, one of the things that you've suggested is that we might be causing metabolic harm to people with weight loss procedures. A second thing, I think certainly, just from a simple general surgeon's point of view, if I perform surgery for someone and they come back with an inguinal hernia and they've had a BMI of 60 and now I've got a BMI of 40, I know that that's actually it's just a more difficult operation to do, because you've got loads of excess skin and fat and tissue, and it is a bit more difficult to get down to the area where the money is, if you like. And I don't know if that's an issue particularly in terms of orthopedic access, and or do we just think that the studies are of such a poor quality, with the exception of Professor Brown's and the meta-analysis, that we need to start again more or less from scratch with some really high quality studies that are jointly designed by bariatric surgeons and physicians and the orthopedic clinicians who will be delivering them, because it strikes me that the evidence is and we've had a really good summary of it, but it's just shocking. I don't know if there's a comment to that.
Right. Is there any comment from the panel? Right, I think we're getting close. One last question I was going to ask the panel myself. When you have a patient who's morbidly obese, to all of you one by one, what do you recommend to them? You, as orthopedic surgeons rather than as bariatric surgeons. Do you ask them to lose weight? And what particular amount of weight would you like them to lose before you actually operate? Or you don't care and you go ahead and say, I'll go ahead and do the operation without you losing weight. You mentioned, I think it was Dr. Bellato talked about a BMI over 40, he wouldn't do the shoulder operation. Do you all have limitations of what BMI you would not operate on? And if you were to recommend them to lose weight, what degree of weight would you want them to achieve? One by one.
Thank you for the question. The American Association of Hip and Knee Surgeons established in 2013 that morbidly obese, so patients with BMI more than 40, but in association with other comorbidities, should not be operated for a denial risk. I think that less than 40, we operate a lot of patients now, so the benefit of total joint replacement is important in the program of weight loss, because our patients that don't walk a lot or stay in the bed. So if we remove pain from the joint, in particular low-bearing joint, is important to weight loss. And another consideration is that the fat distribution. I go fast in my presentation because male in which the fat is more abdominal, we can perform joint prosthesis, knee, hip, or ankle, for example. The problem are the female, in which, not all female, of course, in which the fat is more on the leg. So here we are scared about wound complication. So weight loss is crucial.
Our other members? Yeah.
I personally agree with the problem of loss weight. Of course, is correct. In my hospital, I work with Professor Giardiello, that is a very good obese surgeon, and my advice for the patients is to do an operation for weight loss, but not always is. I can convince the patient to do that. This is my personal observation. In this case, I will not completely disagree to treat surgically the patient, particularly for shoulder surgery. I repeat, for shoulder surgery, using all possibility from the diagnostic aspect, from CT scan 3D, artificial intelligence, to have a good mechanical results. Because I think we have to separate two problems, the mechanical problems from the general problems. And but of course, my advice for this type of patients is to lose the weight, of course.
Okay, well, I think we've just reached just on 2 o'clock, 4 o'clock, sorry. And I'd like to thank the panel for very, very impressive presentations. I'm sure, although there's unfortunately just a few in the audience, most of us have really benefited by your advice and your expertise. Thank you. Hands together. Thank you. Thank you. It was interesting.